With due respect, may I ask that we stand for the Vice Chancellor's procession for this 398th Inaugural Lecture. Thank you. Please, every living soul here, please stand and remain standing. Thank you.
Please, let's be seated, please. I'd like to welcome all of us to this 398th Inaugural Lecture of this great institution, Obafemi Awolowo University, titled A Threefold Cord That Is Not Quickly Broken, the Kinship of the Face, the Teeth, and Quality of Life, to be presented by Professor Kikelomo, Adebanke, Kolawole. Professor Kikelomo Adebanke Kolawole is a professor of orthodontics and honorary consultant at the Obafemi Awolowo University Teaching Hospitals Complex, Ile-Ife. As an alumni of Obafemi Awolowo University, she graduated with the Bachelor of Dental Surgery degree in January 1996 and received the Aubrey Sheham Prize in Community Dentistry, the Fox Taylor Prize in Oral and Maxillofacial Surgery, and the Fagade Prize in Periodontology. She obtained the fellowship of the West African College of Surgeons, Orthodontics in 2005, Master of Science in Developmental Psychology in 2017, and the Doctor of Medicine, MD, of the National Postgraduate Medical College of Nigeria in 2023. Professor Kikelomo Kolawole joined the services of Obafemi Awolowo University in August 2005 and was promoted to the rank of Full Professor of Orthodontics on October 1st, 2017. She teaches orthodontics to undergraduate students and postgraduate resident doctors, and has supervised several resident doctors for the fellowships of the West African College of Surgeons and the National Postgraduate Medical College of Nigeria. She provides orthodontic care to patients at the Obafemi Awolowo University Teaching Hospital Complex. She has over 60 publications in peer-reviewed journals, and her research has focused on perception of facial and dental aesthetics, the impact of malocclusion on oral health-related quality of life, the relationship between craniofacial form and function, oral habits and oral health, and the relationship between craniofacial morphology and sleep-related breathing disorders. She was the acting head, Department of Child Dental Health from 2013 to 2016, substantive head 2021 to 2023, and the Vice Dean of the Faculty of Dentistry, 2017 to 2019. She's an examiner at the Fellowship Examinations of the West African College of Surgeons and has served as external examiner in orthodontics to universities in Nigeria, the Medical and Dental Council of Nigeria, assessment examination for foreign-trained medical and dental graduates, and the Kwame Nkrumah University of Science and Technology Dental School, Kumasi, Ghana. She's a member of the British Orthodontic Society, American Association of Orthodontists, and served as the Assistant Secretary of the Nigerian Association of Orthodontists from 2008 to 2010. She's a member of the Board of Trustees of the Nigerian Sleep Society and staff advisor to the Junior Chamber International Nigeria, JCIN, Obafemi Awolowo University Ile-Ife chapter. She's happily married to the current provost of the College of Health Sciences, person of Professor B.A. Kolawole, with wonderful children. I hereby call on Professor Kikelomo Adebanke Kolawole to present a lecture. Welcome.
I don't know about tomorrow. I just live from day to day. I don't borrow from its sunshine, for its skies may turn to gray. I don't worry over the future, for I know what Jesus said. And today I'll walk beside him, for I know what is ahead. Many things about tomorrow I don't seem to understand, but I know who holds tomorrow, and I know who holds my hand. The Vice Chancellor, principal officers of the university, members of the University Governing Council, distinguished members of Senate, provosts, deans, heads of departments, invited guests, gentlemen of the press, distinguished ladies and gentlemen. It is with great joy and gratitude to God that I stand here today to deliver the 398th Inaugural Lecture of Obafemi Awolowo University, Ile-Ife. I acknowledge that I am a recipient of the grace and mercies of the Lord. Oh, bless our God, ye people, and make the voice of his praise to be heard. I could never have imagined that I would one day work as an academic or live in this ancient city of Ile-Ife. But God, who knows the end from the beginning, brought me here by divine appointment. I was born at the University College Hospital, Ibadan, exactly 52 years tomorrow. I attended primary school in Lagos and then proceeded to the Federal Government Girls College, Shagamu, as the first set of the 6334 system of education in October 1982. At the end of my sojourn in secondary school, I had two decisions to make: the choice of a course of study and the university of study. By the 7th of May 1988, when I wrote the JAMB examinations, I was still 14 years old and had to choose Obafemi Awolowo University. I was also strongly persuaded to pick Obafemi Awolowo University by my father. I had my earliest encounters with OAU in the late 1970s during visits to my mother's best friend. Attending this university was more than an academic choice. It was homecoming. My father was an alumnus of the Faculty of Pharmacy, 1968 set. My mother also obtained a BSc in economics here in 1970. So I stand here today as the daughter of two alumni, the wife of one, the senior sister of one, and the mother of a prospective alumnus, Ayokumi. My younger brother, Ayotunde, followed in my footsteps and studied medicine here, graduating at the top of his class in 2001. The choice of dentistry. The next dilemma I had after choosing a university was the choice of the course of study. I probably belonged to the minority who picked dentistry as a course of first choice. A classmate, Dr. Denola Ayorin, of blessed memory, had muted the idea of studying dentistry. I never gave her opinion a thought until I started considering alternative to medicine. Pharmacy was a familiar terrain with a pharmacist's father and an older sister who was studying pharmacy, so I opted for pharmacy. My dad encouraged me to pursue a degree in dentistry instead. He felt my recurrent visits to the dentist must have stimulated my interest. One day in 1980, I had attempted to sink a post in a tooth in my mouth by myself. I picked up a screw from the floor in my classroom and inserted it upside down into a big carious cavity in my mouth. Curiosity also made me try it right side down, and there it got stuck. After several attempts to bring it out were unsuccessful, I burst into tears and had to be taken to the office of the headmistress. After reading a letter sent home by the headmistress, my disciplinarian father asked me to wait for my mother, who had gone to work at Agege, to return home to Obanikoro, while he returned to his office just a few blocks from the dental clinic. That was the beginning of my numerous dental visits. I only recently got to know, through Dr. Chukuma Emeka, that the name of the now elderly dentist who owned the Solid Dental Clinic is Dr. Edmond Oluwaseun Sholari. I was glad to establish contact with him last February. I cannot count the number of persuasions I got to change my mind about dentistry, but I'm glad I stood firm with my decision. And the rest, as they say, is history. God, in his infinite wisdom, had clarified the worth of the human tooth. So valuable was it that God gave each one the worth of the human eye for eye, tooth for tooth. Towards the end of my undergraduate training, while rotating through medicine posting, I met a young man who succeeded in persuading me to undertake my housemanship here in Ile-Ife instead of Lagos. I graduated at the top of my class in January 1996 instead of 1994, no thanks to the strikes. I obtained prizes in community dentistry, periodontology, and oral and maxillofacial surgery, but my choice of specialty was orthodontics. My first encounter with orthodontic appliances was with a roommate at Shagamu. She had commenced treatment with the famous then Dr. Isikwe in Lagos. Another friend, Dr. Funke Olaniyan, had mentioned that she would specialize in orthodontics. So even before gaining admission, I had started to consider orthodontics as a specialty. When I started clinical postings in dentistry, there was no orthodontist on ground. However, Professor Otuyemi returned after his training in the United Kingdom and taught my class all year-round lectures in orthodontics, which sealed my desire for orthodontics. I completed my residency training and obtained the fellowship of the West African College of Surgeons in 2005, an MSc in psychology in 2017, and the Doctor of Medicine degree of the National Postgraduate Medical College of Nigeria in 2023. I joined the services of Obafemi Awolowo University in August 2005 as Lecturer 1 and was promoted to the rank of Professor on October 1, 2017. It therefore behoves me, with a deep sense of duty, to present my contributions to knowledge through this inaugural lecture. What is an inaugural lecture? I had planned to omit the definition to avoid repetition, but as I posted the notice of today's lecture on social media, a response I got was, "Wait, oh, are you retiring be that? Ha, so fast?" This has therefore necessitated clarifying what an inaugural lecture is again today. An inaugural lecture is a public presentation given by a newly appointed full professor to mark the beginning of their tenure in that position. It is a way to introduce the academic journey to colleagues, students, and the public. What is orthodontics? My postgraduate training was in orthodontics. It is the area of dentistry concerned with the diagnosis, supervision, guidance, and correction of malocclusion. What then is malocclusion? Simply defined, malocclusion is the irregularity of teeth or malrelationship of the dental arches beyond the accepted range of normal. This raises the important question: why the concern about the arrangement of teeth and dentofacial appearance? Malocclusion is a global health problem, ranked in 3rd place by the WHO, following dental caries and periodontal disease. Everyone in this auditorium likely has at least one tooth that is out of place, rotated, crowded, or spaced. So malocclusion is not merely a cosmetic issue. The consequences are regarded as psychosocial, functional, and dental related. Malocclusion has also been linked to broader health issues, including systemic health concerns. The kinship of the face, teeth, and quality of life. Mr. Vice Chancellor, sir, the term kinship typically refers to the social bonds and relationships that connect individuals through blood marriage or adoption. In the context of this lecture, it signifies the inseparable relationship between facial aesthetics, dental health, and overall well-being. It is this deep interconnection that has inspired the title of today's lecture, a threefold core that is not quickly broken: the kinship of the face, the teeth, and quality of life. For the past few years, my research has focused on perception of facial and dental aesthetics, malocclusion and oral health-related quality of life, the relationship between craniofacial form and function, and the association between oral habits and oral health. I have collaborated with colleagues on sleep medicine research more recently. Today I present my humble contributions. This lecture will explore the psychosocial and aesthetic implications of dental and facial variations, the oral health consequences of malocclusion, the biological and functional aspects of malocclusion, and the broader health consequences of malocclusion, and the need for multidisciplinary approaches in healthcare. My introduction to research. My earliest research works were not related to orthodontics, as Professor Itokpo Ogunbodede was the first to introduce me to research. He's here seated with us today. I was invited, along with other officers, to participate in his research works. We investigated the oral health of adult diabetic patients at OAU THC and demonstrated the link between glycemic control and oral manifestations of diabetes. My very first publication was, however, with Professor Vincent Tuboko of blessed memory, It reported post-traumatic nerve injuries among patients treated for orofacial injuries. Our findings highlighted the importance of nerve injury evaluation and documentation prior to patient management. The psychosocial and aesthetic implications of dental and facial variation. Research has recognized that self-esteem and an unfavorable social response are the two interrelated ways by which malocclusion operates against the psychological well-being of individuals. I was privileged to be the first resident trained by Professor Olayinka Donaldo Tuyemi, and this earned me the nickname Crown Princess. While I was a resident, he gave me the task of writing a full manuscript. We investigated perceptions of parents and their patients and their parents of dental appearance and compared their opinions with treatment need registered by orthodontists. The aesthetic component scale of the IOTN, which has 10 colored photographs showing different levels of dental attractiveness, was employed. Our results showed that parents were more objective and had the strongest correlations with the orthodontist, while the least was between the patients and the orthodontist. We corroborated previous observations that individuals underestimate the severity of their malocclusion. Towards the award of the Fellowship of the West African College of Surgeons, I investigated the orthodontic concern and treatment awareness of children and their parents compared with objective treatment need. The highlights of our study were that facial and dental appearance were assessed independent of each other. The school children expressed greater orthodontic concern than their parents, while parents in the referred population were more motivated for orthodontic treatment. Subjective and professional assessments of orthodontic treatment need were also found to be different. Evaluation of the perception of dental aesthetics with the IOTN is not without its limitations. We therefore evaluated the self-perception of undergraduates with the oral aesthetic subjective impact scale and a visual analog scale. Our findings revealed that the OACs and VAS were able to discriminate between participants with different degrees of treatment need and are therefore valid tools for evaluating orthodontic treatment need. Nickname and bullying in relation to dental appearance. Research has shown that malocclusion may make individuals more susceptible to nicknames and bullying. We therefore assess the incidence of nicknames and the relationship with dental appearance among school children. Our paper was the first attempt to determine the impact of nicknames on psychological well-being in Nigerian adolescents. It was obvious from our study that being given nicknames is a common occurrence in Nigerian schools, with 3 out of every 4 children being nicknamed. Most of the nicknames were derived from children's names, while 32.6% were related to appearance. Teeth were the source of the nickname in only 4.7% of children. More recently, with the rise in internet use, we examined the prevalence of nickname and bullying in relation to dental appearance among school children under my supervision. The majority had nicknames. However, only 5.3% was also due to dental appearance. Bullying was also a common occurrence. Orthodontic treatment need differed between participants with and without nicknames, but not between bullied and non-bullied participants. Social judgments made by children in relation to dental appearance. Secondary school students rated the personalities of 5 adolescents from frontal face radiographs showing normal occlusion and various classes of malocclusion presented in random order. We found that the adolescent with class 1 malocclusion was the most positively judged, while the adolescent with class 2 division 1 malocclusion was the most negatively judged. Mr. Vice Chancellor, sir, while positive and negative attributes such as clever, kind, honest, confident, careful, stupid, naughty, and rude cannot be determined by the arrangement of teeth, these attributes were used by adolescents to raise the personalities of other adolescents. This shows that the face, the teeth, and quality of life are a threefold cord that is not quickly broken. We investigated the perceived orthodontic treatment need of final year dental students because of their level of understanding of orthodontics. We found that self-perceived and normative treatment need differed significantly, implying that the perception of treatment need and treatment uptake do not solely depend on dental awareness and knowledge. Malocclusion may complicate the problem of discrimination that individuals with special health care needs face. We determined the orthodontic treatment need of children with special health care needs residents in Ile-Ife. It was observed that significantly more children with special health care needs had great need for orthodontic treatment based on the Index of Orthodontic Treatment Need and the DAI. The need for treatment of participants with intellectual disability, visual impairment, and multiple special health care needs differed significantly from the control group. To the best of our knowledge, our study was the first to perform a comprehensive evaluation of orthodontic treatment need in this population using a combination of indices. Our findings of significantly greater need for orthodontic treatment in children with special health care needs justifies the prompt provision of treatment to these individuals. Such treatment will improve their appearance and social acceptance. Objective evaluation of facial aesthetics. In our earlier studies, we had examined the subjective evaluation of facial aesthetics. We therefore embarked on objective assessments using anthropometry and photometry. We determined the facial dimensions of a group of young adults and the dominant facial type. Facial dimensions were significantly larger amongst males. Although not significant, nasofacial frontal angle was the only dimension that was greater amongst females. The dominant facial type was round for females and very long face for males. The highlight of our study, however, was the observation that nasal base width dimensions did not approximate intercanthal distance as previously reported. This observation makes it imperative that orthodontic treatment is provided based on this standard for Nigerians. Further attempts to objectively assess facial attractiveness led to the evaluation of facial proportions and determination of golden ratio. The golden ratio is considered as the ideal ratio for beauty. It is a numerical value with the facial length being 1.618 times more than the facial width. Studies have proven that harmonious faces of beautiful women follow the golden ratio, while others show the contrary. Pallet et al. Opines that attractiveness is optimized when the face's vertical distance between the derived facial proportions of photographs judged as aesthetic and unaesthetic by independent undergraduates evaluators were similar. Our observation corroborates the opinion that variations from ideal ratios can be compatible with pleasing facial aesthetics. Perhaps beauty really lies in the eye of the beholder. Determinants of perceived physical attractiveness. To fulfill my desire to understand further the psychological impact of malocclusion, I pursued a master's degree in psychology. I was fortunate to be taught and mentored by many erudite psychologists and supervised by Emeritus Professor Fumitogonu Bukestet, who is present here with us today. I remember with much gratitude Professor Kolawole of blessed memory. I investigated the determinants of perceived physical attractiveness amongst adolescents. The face and ears were rated as the most attractive body parts. Females, however, perceived some specific body characteristics, such as the mouth, the teeth, the nose, and the face, as more attractive than males. We were able to again demonstrate the aesthetic value of the face and corroborate previous reports that general physical attractiveness seems to be better predicted by ratings of facial attractiveness than any other body part. We found that adolescents' self-esteem predicted their self-perception of physical attractiveness. Our findings therefore upheld the assertions of Abraham Maslow that self-esteem is a basic human need. Measuring oral health-related quality of life. The connection between malocclusion and quality of life is complex and conflicting evidence exists. Oral health-related quality of life involves evaluation of an individual's oral health, functional and emotional well-being, expectations and satisfaction with care, and sense of self. Multiple item questionnaires are the most widely used methods of evaluating quality of life and include generic and condition-specific instruments. We measured the impact of oral diseases on the quality of life of a sample of children with the child's perception questionnaire. Children with more severe malocclusion and high caries experience did not report worse quality of life than their counterparts. Significant correlations were observed between quality of life and oral health and overall well-being. More recently, We compare the performance of the child's perception questionnaire with the short versions of the CPQ as evaluating quality of life. The CPQ was shortened to 16 and 18 items through the item impact and regression methods to enhance its psychometric properties. We found that the short item questionnaires detected greater impact of quality of life than the original CPQ. They also showed better correlation with global ratings of well-being. With regards to length, the 16-item version performed better and may be the preference for clinical use and epidemiological surveys. In another study, the impact of malocclusion on quality of life was determined with the malocclusion impact questionnaire, a relatively new condition-specific tool developed for adolescents. The MIQ was used against the CPQ, which served as the gold standard. The MIQ identified the impact of malocclusion on quality of life, although a gradient based on malocclusion severity was not observed. Age was a significant predictor of quality of life, with the increasing age accounting for improvement in quality of life. Our score standardized to 100% gave higher scores with the MIQ, indicating that this condition-specific tool is more sensitive. We got our manuscript published in the Apex Journal of Orthodontics, the American Journal of Orthodontics and Dentofacial Orthopedics. In a more recent study, the relationship between quality of life determined with the MIQ and nickname and bullying experience was examined. Quality of life did not differ between participants with and without nicknames and bullied and non-bullied participants. No difference in quality of life was also identified based on malocclusion severity. The focus of our initial studies was on children, but with increasing acceptance of braces, a sizable number of orthodontic patients are now adults. The psychosocial impact of dental aesthetic questionnaire, a condition-specific quality of life measure, was developed for adults. We investigated a sample of undergraduates. Our study revealed that participants with varying degrees of malocclusion demonstrated significant differences in well-being, with the dental self-confidence being most significantly affected. In another study, we evaluated dental students also with the PDAC. Quality of life differed significantly according to malocclusion severity. There was a decrease in self-confidence, and the psychological and social impact and aesthetic concern were worse as malocclusion severity increased. Aesthetic concern demonstrated the greatest impacts, also upholding the opinion that visible irregularities elicit the greatest dissatisfaction with dental appearance. Measuring quality of life of orthodontic patients. Orthodontic treatment is frequently sought to improve aesthetics and enhance quality of life. The impact of malocclusion on the quality of life of patients requiring fixed appliance therapy was assessed with a generic measure and a condition-specific measure. We were able to demonstrate significant and progressive worsening of quality of life with increasing malocclusion severity. We, however, observed a weak and negative correlation between the generic and condition-specific measure. The generic and condition-specific measures are therefore complementary and not alternative sources of information. Changes in quality of life during fixed appliance treatment. We also investigated early changes in quality of life during fixed appliance therapy. Quality of life was assessed at baseline 1 week, 1 month, 3 months, and 6 months after commencement of treatment. We were able to demonstrate that wearing of fixed appliances caused a significant deterioration in quality of life during the first week to first month of commencement of treatment. This was attributed to the initial discomfort and limitations associated with appliance use. Progressive and significant improvements in quality of life were, however, evident with the PDAC throughout the study duration. The significant improvement in dental appearance, dental confidence, social interactions, and psychological well-being showed tangible evidence that malocclusion does impact quality of life, and treatment with fixed appliances gives remarkable improvements in quality of life. Mr. Vice Chancellor, sir, a threefold cord is not quickly broken, and neither is the kinship between the face, the teeth, and quality of life. An individual's experience of social and emotional impacts of malocclusion can also be influenced by the psychological profile, including personality disorders. Under my supervision, the interrelationship between personality disorders, orthodontic treatment need, and quality of life was evaluated. The dependent personality disorder was the most prevalent. Individuals with avoidance, obsessive-compulsive, schizoid, and narcissistic personality disorders exhibited significantly worse quality of life. Self-esteem was also significantly lower amongst individuals with paranoid, avoidance, schizoid, and antisocial personality disorders. Our study was able to demonstrate that personality disorders have significant and varying effects on quality of life, self-esteem, and orthodontic treatment need. The high prevalence of personality disorders observed in this study was an eye-opener to the possibility of its occurrence in prospective orthodontic patients. We recommend collaborations between orthodontists, psychologists, and psychiatrists for management of such cases. The oral health consequences of malocclusion. Opinions about the contribution of malocclusion to the etiology of dental caries and periodontal health are conflicting. This led us to investigate the relationship between irregularity of teeth, lip competence, and periodontal health. Our findings demonstrated that crowding and lip incompetence were risk factors for poor oral health. More recently, we investigated the association between specific malocclusion traits, caries, oral hygiene, and gingival health of children with mixed dentition. We found that increased overjet and anterior open bite significantly increased the odds of having gingivitis. Children with buccal crossbite had more than 6 times increased risk of having caries. This association between buccal crossbite and caries had not been highlighted in any study prior to ours, to the best of our knowledge. The result of our study once again highlights that there are direct oral health risks associated with malocclusion, justifying orthodontic treatment. Caries and gingivitis resulting from untreated malocclusion can set up further oral health and systemic health problems. Gingivitis is associated with increased risk of cardiovascular disease, type 2 diabetes mellitus, adverse pregnancy outcome, and osteoporosis. Oral habits and oral health. I co-pioneered the establishment of an oral habit study group in 2013. Oral habits are body-focused repetitive behaviors in which there is an irresistible urge to perform. They include digit sucking, lip sucking, nail biting, tongue thrusting, and bruxism. Oral habits in childhood are often considered normal and may be overlooked. Evidence shows that some fetuses suck their digits in utero. When oral habits persist beyond the age of 5 years, they may reflect anxiety or other emotional problems. Persisting in this behavior can also lead to other issues, including problems with digits, infections, and exacerbating existing psychological distress. Oral habits have been a subject of intense international research. However, our search through the literature identified several gaps in Nigeria. To address this, we conducted a household survey among children below 12 years in Ife Central Local Government of Osun State. We determined the prevalence of oral habits as 13%, with digit sucking observed as the most common oral habit. Digit sucking was not a significant predictor of caries and oral hygiene status. The role of infant feeding practices as the predictor of oral habits was also investigated. A significantly higher proportion of children who are not exclusively breastfed had digit sucking and object biting habits. The odds of having oral habits was significantly reduced for children who are exclusively breastfed. Our findings justify supporting and promoting exclusive breastfeeding. Digit sucking can represent untreated anxiety or other emotional problems. We assessed the level of general and dental anxiety of children. It was observed that 12.9% had high clinically significant trait anxiety, while 52.7% had high dental anxiety. Digit sucking was, however, not a predictor of dental anxiety and general anxiety. Perhaps, if more culturally sensitive instruments were available for measurement of anxiety, our results may have been different. This calls for collaboration between colleagues in child dental health, psychiatry, and psychology. We explored the association between the child's family structure and the presence of oral habits. The number of siblings a child had was significantly associated with the presence of oral habits, as children with 2 to 4 siblings had a higher probability of engaging in oral habits. Oral habit breaking methods. Effort made by parents to break oral habits are informed by their knowledge, attitude, and with professional advice rarely sought. There is an anecdotal report of a gangrenous finger in a child that required amputation due to overzealous attempts of parents to break a digit sucking habit here in Ile-Ife. We therefore tried to identify oral habit breaking measures instituted by mothers. We found that 65.1% of mothers made efforts to break habits. The most common methods used were punishment and application of unpleasant flavored substances. Only 20% of concerned parents sought professional advice. There was no significant association between age, mother's level of education, and the use of professional or non-professional methods to break oral habits. Public awareness needs to be raised about the availability of professional services for managing oral habits. Information on the cumulative effect of the frequency, intensity, and duration of practice of oral habits on occlusion was lacking in our environment. We therefore developed a digit sucking severity index. The only 16.9% of participants were severe digit suckers. The most common malocclusion traits among participants who engage in oral habits were spacing, crowding, and increased overjet. Tongue thrusting and bruxism were significantly associated with greater severity of malocclusion, probably because of the possibility of indulging in these habits for long uninterrupted periods. To the best of our knowledge, this was the first community-based survey conducted on oral habits in Nigeria. This household survey permitted the inclusion of preschool children, an age category that is highly important for oral habits. It therefore likely to have provided a true representation of the prevalence of oral habits and malocclusion in children. The biological and functional aspects of malocclusion. The anatomical architecture of the craniofacial complex is both a determinant and consequence of the functions it supports. Bimaxillary proclination or full mouth appearance is a dentoalveolar condition associated with the proclination of upper and lower incisors. We evaluated the relationship between tongue dimensions and bimaxillary proclination. Tongue thickness, tongue length, and intermaxillary space length were significantly greater in the bimaxillary proclination group. However, overjet and interincisal angle were the only predictors of bimaxillary proclination. Our findings also suggest that oropharyngeal airway dimensions do not significantly differ between individuals with bimaxillary proclination and those with normal incisor relationship. Occlusal and dental arch dimensions of children with adenoid hypertrophy. The effects of adenoid hypertrophy on the occlusion and dental arch dimensions of children were evaluated. We were able to demonstrate that the presence of hypertrophied adenoids affects the occlusal characteristics in the 3 planes of space, with a greater occurrence of class 2 division 1, posterior cross bite, anterior open bite in adenoid patients. The arch and palatal vault dimensions of these children were also determined. We observed shorter arch dimensions, which were more evident in the mandible, which may represent somatic growth impairment due to frequent arousals during sleep. Adenoid subjects also had significantly increased palatal height and reduced palatal volume compared to control subjects. Our findings have implications for the practice of orthodontic patient care. Class 2 division 1 malocclusion significantly affects quality of life because of its visibility. Early interventions with normalization of nasal airflow will therefore be beneficial. Reduced palatal volume also connotes a reduction in tongue space. Caution should therefore be exercised with prescription of extraction for patients with enlarged adenoids during comprehensive orthodontic care. This study once again demonstrated the relationship between the face, the teeth, and quality of life. When teeth are habitually kept apart due to mouth breathing, the postural alterations lead to further disruption in teeth arrangement, jaw dimensions, and this worsens quality of life. Building on our previous research on oral habits and oral health, we investigated the impact of digit sucking on masseter muscle thickness. We demonstrated that masseter muscle was thicker among digit sucking patients, both in the contracted and relaxed states. The width of the nasopharynx was also significantly decreased among these digit suckers. Our findings provide valuable insights into the potential influence of digit sucking on craniofacial and airway development. Digit sucking caused significant narrowing of the nasopharynx and a more inferiorly and anteriorly positioned hyoid bone, which is associated with the presence and severity of obstructive sleep apnea. This suggests that digit suckers are at a risk of developing obstructive sleep apnea, which is associated with significantly impaired quality of life. Mr. Vice Chancellor, sir, our findings provide evidence that putting a little finger in the mouth can affect oral health, facial morphology, airway function, and negatively impact quality of life. Sir, the kinship of the face, the teeth, and quality of life are indeed a threefold cord that is not quickly broken. Research and clinical practice nexus. One of the benefits of conducting research is the translation of research findings into practice for more efficient clinical management of patients. We therefore conducted research on various aspects of fixed appliance therapy. Orthodontic separators are used in the interproximal contact points of teeth to create space for banding during fixed appliance therapy. We investigated patients' pain perception, associated discomfort, the dislodgement rate, and separation effectiveness of 4 types of orthodontic separators: dumbbell, elastomeric round, stainless steel, and nickel titanium metallic separators. The study demonstrated that the dumbbell separator induced the highest pain. Patients experienced the peak pain at 48 hours post-insertion, with the greatest discomfort experienced during eating. It was also noted that the dumbbell separators achieved the greatest separation effects. The dislodgement rates were determined as 7% for dumbbell, 2% for round and nickel titanium, while stainless steel was 0%. Our study findings will serve as a guide for orthodontists. Dumbbell separators will be useful in achieving quicker and greater separation when the patient's pain threshold is high. Nickel titanium may be considered in patients with low pain threshold, while stainless steel separators could be considered when banding of teeth may be delayed for about a week, since the risk of dislodgement is minimal. Tooth alignment during fixed orthodontic appliance therapy. Extraction of false premolars is often carried out before fixed appliance therapy to create space for alignment of teeth. We therefore explored the effect of healing time of extraction sockets of the duration of tooth alignment for patients with anterior segment crowding. The extraction protocols were adjudged recent and healed when the treatment was commenced within 3 to 7 days and 5 to 6 weeks post-extraction, respectively. Patients were followed up for the first 16 weeks of treatment. Our investigation indicated that alignment rates did not differ significantly between the recent and healed extraction cases, between males and females, and in the maxilla and the mandible. A significant difference was, however, identified between adolescents and adults, which was, age group was the only predictor of alignment rate. Mr. Vice Chancellor, sir, through our research, we have documented findings that now serve as valuable clinical guidelines influencing fixed appliance therapy. It is imperative that we adopt practices that alleviate pain, reduce bond failure, minimize treatment time, and enhance treatment outcomes so that the quality of life of those entrusted to our care is not compromised but improved during their orthodontic journey. The face, the teeth, and quality of life are indeed an inseparable threefold cord. Collaborations with other specialties. My interest in dental erosion and dental hypersensitivity arose because it happens to be an oral health challenge which I also face. Dental erosion is characterized by the progressive loss of tooth enamel due to chemical processes. Dental erosion may therefore compromise orthodontic bracket placement, apart from the additional risk of damage to the tooth during bracket bonding. The pain sensitivity experience and aesthetic consequences can also negatively impact self-esteem and quality of life. In an extensive review of the literature, we highlighted the erosive capacity of soft drinks and foodstuffs, and we found that it is significantly associated with chemical factors. We noted that the phosphoric acid content of cola drinks reduces its erosive potential when compared with fruit juices that contain citric acid. The risk of erosion also bears a strong relationship with the amount, frequency, method of introduction of drinks into the mouth, drink temperature, dilution, practice of healthy lifestyle, oral hygiene practices, and saliva composition. We also reported a case of a 49-year-old woman referred for tooth wear and sensitivity. The history of inappropriate use of lime juice for weight control was identified. Clinical management of teeth with pulp canal obliteration. Pulp canal obliteration is a sequelae of tooth trauma, which patients with protruding incisors and incompetent lips are particularly prone to. This may pose a management challenge before the commencement of orthodontic treatment. The clinical signs and symptoms associated with PCO and the status of the periapical tissues were assessed with the periapical index. Our study findings indicate that endodontic treatment should be initiated in teeth with tenderness to percussion, PAI scores greater than or equal to 3, and a negative response to sensibility testing. Mr. Vice Chancellor, sir, orthodontic treatment planning demands thorough diagnostic evaluation, guided by clinical expertise and sound judgment. The temptation to initiate treatment without consideration of all pertinent factors, including oral pathologies, must be avoided. Optimal care may necessitate collaboration with other departments for lasting improvements in aesthetics, dental health, and overall quality of life. The broader health consequences of malocclusion and the need for multidisciplinary approaches in healthcare. When severe skeletal deformities exist, the goals of attaining acceptable occlusion, aesthetics, and function are impossible with orthodontic treatments alone. Such cases may only be amenable to orthodontic surgery. We reported the highlights of the collaborative effort between the Department of Oral and Maxillofacial Surgery and the orthodontic unit at the Obafemi Awolowo University. A framework for improving surgical orthodontic collaborative care of patients in our center was developed and adopted. The functional need for orthodontic surgery of an orthodontic patient population was also determined with the index of orthodontic functional treatment need. About 42.6% had no need for treatment, while 46.8% had great need for orthodontic treatment. We found that increased overjets, increased overbites with the evidence of dental or soft tissue trauma and speech difficulties were the main indicators for orthodontic treatment. To the best of our knowledge, this is the first report of the functional need for orthodontic surgery in a Nigerian population. The high prevalence of severe malocclusion with functional orthodontic treatment need suggests that a substantial proportion of the Nigerian orthodontic population have malocclusions that will benefit from both a combination of orthodontic and surgical interventions. This underscores the importance of comprehensive orthodontic assessment of all orthodontic patients and serve as a justification for multidisciplinary management and government funding of orthodontic care. The practice of sleep medicine in Ile-Ife. The association between the craniofacial area, upper airway morphology, and sleep-related breathing disorders is poorly understood and somewhat controversial. Sleep medicine is a rapidly growing field globally. The Sleep Study Group of OAU-THC was constituted in 2018 on the initiative of Professor K.G. Komolafe. It has now metamorphosed to the Nigerian Sleep Society. The knowledge of Nigerian medical and dental students about sleep medicine was investigated. Our results highlight the need to allocate adequate lecture hours to teach sleep medicine in the medical and dental curriculum to improve their knowledge. We contributed a chapter, Current Practice of Sleep Medicine in Nigeria, to a book. The apparent rise in the occurrence of sleep problems in the Nigerian population was noted. The minimal involvement of orthodontists and oral maxillofacial surgeons with sleep medicine practice in Nigeria was also highlighted. The prevalence of sleep-related breathing disorders and its association with malocclusion traits in a population of Nigerian undergraduates was also examined. Individuals with pathological sleepiness were more likely to present with convex facial profile, class 2 skeletal pattern, angles class 2 malocclusion, and incompetence. The high report of pathological sleepiness and its significant association with malocclusion features highlights the compromise in quality of life that can occur across multiple domains with the presence of malocclusion. Mr. Vice Chancellor, sir, I humbly submit again that the face, the teeth, and quality of life are a threefold cord that is not quickly broken. Collaborations with information and communication technology. We have collaborated with colleagues in the Department of Computer Science and Engineering of the Faculty of Technology to develop a mobile application called the Ife OrthoCare mobile app, which illustrates oral hygiene instructions, remind patients about oral hygiene compliance, and empowers clinicians to monitor. A greater reduction in biofilm accumulation was recorded with the aid of this application. More recently, we obtained a TED Fund research grant for a project titled Integration of Tele-Dentistry Model into the Delivery of Oral Health Care Services in Rural Communities in Nigeria. Service. Mr. Vice Chancellor, sir, the responsibilities of an academic include teaching, research, and service. I have found teaching both fulfilling and rewarding. I have taken up the responsibility of parenting many students who call me mommy tenderly to the annoyance of my daughter. It is always a delight to receive messages and calls from many of them in diaspora updating me about their progress. I also serve as a staff advisor to the Juniors Chambers International, OAU chapter. I have also been privileged to pass on the training I received as the Crown Princess to others. I have supervised and co-supervised the thesis of many younger colleagues towards the award of the fellowships of the West African College of Surgeons and the National Postgraduate Medical College of Nigeria, who are now specialists in orthodontics and practicing in various locations in Nigeria and in the diaspora. I have served both as acting and substantive head of the Department of Child Dental Health. During my last tenure, with the aid of a TED Fund grant, we were able to equip our orthodontic laboratory. I served as the Vice Dean of the Faculty of Dentistry from September 2017 to May 2019. I've been a member of the College of Health Sciences Induction Planning Ceremonies Committee since 2008, and I've chaired the committee since 2021. I've also served in the Alumni Relations Committee of the College of Health Sciences. I was appointed an honorary consultant in the teaching hospital in 2005. Together with other colleagues, we have been able to establish an orthodontic center that is renowned for rendering quality care. With the support of grants from the Smile Train and the Nordoff Craniofacial Foundation, I've had the opportunity to attend international trainings in cleft care and dental facial care at the Changong Craniofacial Center at Taipei, Taiwan, on several locations between 2008 and 2014. With the training acquired, I've been able to initiate and establish the provision of pre-surgical nasolabial molding to patients born with orofacial clefts, which is the standard of care worldwide, which hitherto was not practiced in our center. I have contributed to national and global orthodontic awareness. The first elaborate celebration of World Orthodontic Health Day in Nigeria, held here in Ile-Ife in May 2017, which I initiated and coordinated. I have served as an examiner at the Fellowship Examiners of the West African College of Surgeons and as external examiner to universities in Nigeria and the Kwame Nkrumah University of Science and Technology, Ghana. I have also participated in accreditation exercises and as external examiner as the assessment examination of foreign-trained medical graduates. I belong to several professional bodies and have attended several local and international conferences. I am a member of the Board of Trustees of the Nigerian Sleep Society. I joined the New Covenant Church in 1994 on the invitation of a friend, Dr. Abiola Adeniyi. Through the grace of God, I have had the privilege to be a co-laborer in the Lord's Vineyard. I obtained a diploma in pastoral ministry in 2002, a diploma in ministerial studies in 2004 from the Covenant Bible College, Ibadan. I was ordained a reverend in July 2013. Conclusions and recommendations. Mr. Vice Chancellor, sir, in the time allotted to me, I have tried to highlight the central truth that the face, the teeth, and quality of life are not separate concerns, but members of a profound kinship. Based on these research findings, here are some of my recommendations. The federal government needs to prioritize oral health by making oral health visits for the child patients. Government funding of dental education and increase in dentistry admission quota is inevitable. The number of orthodontists that can provide specialized care to the Nigerian population is grossly inadequate and cannot be met with the current admission quota for dentistry. Findings from our study justify the routine use of standardized occlusal indices in the Nigerian orthodontic practice. The need for the development of culturally sensitive patient report outcome measures cannot be overemphasized. The government also needs to invest in the establishment of specialized centers for management of dentofacial deformities. The significant number of individuals with functional need for orthodontic treatment calls for advocacy for multidisciplinary care of patients. The high prevalence of pathological sleepiness and its association with malocclusion highlights the need for interdisciplinary management of sleep disorders. Our research findings on oral habits also justifies promoting exclusive breastfeeding. Our research works represent only a tip of the iceberg. I do not intend to rest on my oars. There remains a vast expanse of uncharted territory, offering numerous opportunities for further inquiry. We will continue to ask questions, nurture interdisciplinary collaborations, and strive for outcomes that transform lives. Mr. Vice Chancellor, sir, while I was reluctant to come to Ile-Ife, the one who knows tomorrow destined Ile-Ife to be home, and Ile-Ife has been home. What shall I render unto the Lord for all his benefits to me? Words are insufficient to offer my sacrifice of thanksgiving to my stone of help. Hitherto have you helped me. I bow my head, I worship you. I appreciate the past and present university leadership for providing the conducive platform for academic excellence. In the same vein, I appreciate the past and present management of Obafemi Awolowo University Teaching Hospital Complex. If I have seen further in research, it is by standing on the shoulder of giants. I acknowledge with many thanks the tutelage and guidance of our academic giants, Professor Olayinka Donaldo Tuyemi, whose sacrifices and dedication laid the foundation for my journey and whose example continues to guide my steps. Professor Tuyemi is still actively initiating and conducting research as I speak. This moment is a tribute to the wisdom, patience, and investment of the one who taught me. I make bold to say I was properly trained. May your generations be blessed, sir. I acknowledge with many thanks my many teachers and trainers, Professor Oluyini Olushile, and Professor Segun Fagade of blessed memory. Professor Itokpo Ogunbodede, who is here present with us. Professor Comfort Adekoya Shofora. I acknowledge all my senior colleagues in the profession. Professor Zola Soji, Olaomi Fatusi, Owotade, Kizito Ondukwe, Adeleke and Fadekemi Ogini, Professor Morenike Okpong, and Professor Temitokpe Eson. In the twilight of my beginnings, it was Professor Morenike Okpong who read my earliest drafts and guided my steps into the realm of writing. I am deeply grateful. I appreciate my dear friend and classmate, Professor Tokunbo Bamishe, and my brother, Professor Michael Adedigba. I appreciate especially Professor and Mrs. Folusho Owotade, Professor and Mrs. Kendi Oluwadia, the Ronkus, my body for life. My special thanks goes to my younger colleagues in orthodontics. Many of them are here present. My deep appreciation also goes to past and present residents, students, and the many children OAU has given me. Gratitude is due to the generations of dental surgery assistants and technologists who have helped to ensure that patients are efficiently cared for. I thank all serving and retired members of staff of the Dental Center OAU THC. I wish to express my gratitude to the national and international leadership of the New Covenant Church and my many spiritual fathers and mothers here present. No expression can truly capture my sincere gratitude to God for my late father, Pharmacist Adebanke. His love, discipline, tutelage, guidance, and depth of wisdom were unmatched. Daddy had too many rules. He would say, I appreciate my loving and gentle and hardworking mother, Dickiness Eitayo Ajao Bamimore, small but mighty. I thank God for preserving your life to witness this day. Mommy's catchphrase was, that was indeed no hiding place with both. Blessed indeed is your womb and the paps that I sucked. I've been privileged to have more than one mother. I acknowledge with gratitude my fashionista Egba mother, Mommy Yewande Ekundayo, my mother's best friend of 67 years, and my mother for the past 37 years. I'm deeply thankful to the parents God gave me by marriage, Emeritus Professor Lawrence Babatokpe and Mommy Eunice Adejumoke Kolawole. They say you do not choose your in-laws, but if I have been given the choice, I will choose you all over again. I recognize the contributions of my many aunties and uncles, living and of blessed memories, my cousins, and the extended Bamimore and Ajao families. To my beloved siblings, Omolara, Ayotunde, Olabolanle and their children, you have been my first friends, my gist partners, and my lifelong supporters. Thank you for cheering me on. I appreciate Ayotunde especially for flying all the way from the United States to be here today. Your presence speaks louder than any words, and I am deeply grateful. I'm blessed to have acquired more brothers and sisters. I acknowledge my many siblings in love. Oluremi and Olabode, Babatunde and Oyenike, Babalola and Bolariwa, Tokumbo and Eyumi, and the Kolawole football team. I've been privileged to journey through life with a special group of ladies, the FGGC Shagamu alumni. Some of them are here present. And the IFE Med 95 medical and dental class. I thank you all. To my treasured friends who have graced this occasion physically, and for those who have come from afar, I thank you. I appreciate Mr. Abayomi Omolagba, my husband's childhood friend, who flew all the way from the United Kingdom to be part of today's program. I thank my inaugural lecture planning committee for your kind assistance and support. One of the benefits of providing orthodontic care is that you will get to interact with patients for several years. Many of my past patients and their parents are now family members and are present with us today. I thank and appreciate you. My warmest appreciation goes to the wonderful children God gave me to raise, Baba Tokpe, Ayokumi, and Ayomiku Opemikpo. Thank you for being pure joy, peaceful, and walking this journey with grace. I'm proud to be your mother. May your path shine brighter and brighter. Gratitude overflows as I recognize my dear husband, Baba Tokpe Ayodeji. The gentle force that altered the course of my life. If I had not married you, I would not be in academia at all. Sharing life with you has been one of God's greatest gifts to me. A journey of shared purpose, quiet strength, and boundless grace. Thank you for your leadership, sacrifices, and support. Thank you for being a role model I can emulate. You know that I love you. After all is said and done, I am mindful that it does not all end here. Beyond the attainments here, my greatest attainment has been Christ in me, the hope of glory. I have a hope of glory. I have laid hold on eternal life. I admonish you to pursue this hope too, that you may also lay hold on eternal life. Mr. Vice Chancellor, sir, distinguished ladies and gentlemen, I thank you for your attention.